Good afternoon, everybody, and thank you for joining us in our health seminar, which is organized by the Center for Primary Health and Social Care. So I'm very pleased to introduce our speaker today, which is Dr. Dennis Stefler, who has taught actually in the past at London Metropolitan for the MA and BCSE courses in public health. And so it's great to have him back for our seminar today. Dennis is Senior Research Fellow in Epidemiology and Public Health at the Institute of Epidemiology and Health at UCL. He has worked for many years now with the Central and Eastern European Health Research Group at UCL. And he's also part of a team of the EU-funded ATHLOS, which I love the name, ATHLOS. I mean, it's Greek, obviously. And the ATHLOS project, which is about aging trajectories of health. So the topic of his seminar today is about the traditional Eastern European diet and its relationship with mortality by presenting some findings of the health, alcohol, and psychosocial factors in Eastern European study, which is a HAPIEE. Well, I'm sure he's going to clarify all those things later on. So we will have time for questions and answers at the end of the presentation, but I'll encourage the audience to use the chat box as we go along. Please do, so we can then get back to those questions at the time for discussion. So over to you, Dennis.
Okay, very warm welcome, everyone. Thank you very much for coming, and wish you a very nice afternoon in this cloudy April day. Yolanda introduced me well, so I don't really want to add anything. Yeah, so I'm from UCL, and I did teach at the London Metropolitan University a few years. I really enjoyed that. And today I will talk about food and health from the public health perspective, and I will specifically focus on the traditional Eastern European diet. So I know that some of you may be familiar with the nutritional epidemiology and the public health nutrition, but I suspect that not everyone in the audience is very clear about these disciplines. So I thought I will start my talk with a very general part, where I will introduce some key principles of nutritional epidemiological research and public health nutrition. I thought this would be useful for those people who know a lot about these areas, just as a recap, but it would be also useful for those people who are not working in this field and coming from other disciplines, just to give an overview on some general concepts. So that will be the first part, probably the shorter part of my talk. And in the second part, I will talk about a very specific analysis, a study that we did with my colleagues here at UCL in the last few years, where we looked at traditional Eastern European diet and its relationship with mortality in a large prospective cohort study called the HAPIEE study. So that part of the talk will be probably slightly longer and more detailed, more specific to a certain analysis, but some of the general concepts that I introduced in the first part will come back in the second, and hopefully I will give a good specific example about the general ideas I talked at the beginning. So I plan this to cater for everyone, and yeah, I hope that you will enjoy this next maybe an hour. And all of you will find something to take home from this presentation. So then I will start now, because this was just the very beginning. So I think where I would like to start is just a very brief introduction of nutritional epidemiology and public health nutrition. So epidemiology and public health are branches of science or medicine that focus on disease and health from the population point of view. And one of the main aims of our work in this discipline is to understand the causes of chronic and acute diseases and understand those factors that may contribute to the development of cardiovascular disease, cancer, Alzheimer's disease, or COVID-19. We do this in order. We do this we try to understand the causes of disease in order, because if we know the causes of the disease or those risk factors that contribute to the development, we are able to intervene. We are able to prevent the development of these diseases in the future. So here in epidemiology and public health, we really emphasize and focus on prevention rather than treatment. And within epidemiology and public health, nutritional epidemiology and public health nutrition are branches that look at dietary risk factors, dietary causes of our health, or dietary causes of certain diseases. In other words, we are looking at in our work the relationship between certain eating habits, dietary factors, and diseases in the population. So within this work, we can explore any components of our diet. So for example, we can decide to focus on the smallest components of our diet, which are the nutrients. We can look at protein intake in relation to heart disease, or vitamin C consumption in relation to cancer, or trace elements, or any nutrients basically that you are interested in. However, it's important to know that we don't eat nutrients on their own, but we eat nutrients as part of foods. And foods are another slightly bigger components of our diet. And we can also focus on foods like fruits, vegetables, meat, or any other food groups or individual food items in relation to chronic or acute diseases. However, our diet, while we eat, and in our diet, we don't eat foods on their own either. We eat foods and nutrients in combination with each other. And I don't just mean that we eat sausage with mash, or curry and rice together. But what I mean is that there are about, I don't know, 50 or 100 different food items that an individual eats on a habitual level, on a regular basis. And this combination of foods and nutrients provide the overall diet of that individual. And it is possible to focus on the overall diet as well in this nutritional epidemiological analysis. And in technical terms, we call this combination of foods and nutrients dietary patterns. There are some examples like the Western style diet, Mediterranean style diet, and the traditional Eastern European diet, which I will talk about in the second part of my talk, also an example for overall dietary pattern that can be explored, and of which connection with health or disease can be investigated. So if you look at publications in the literature, you see that in the 90s, early 2000s, or 80s, 90s, early 2000s, most nutritional epidemiological research focused on nutrients and foods. But today there is a trend that more and more analysis and research focus on overall dietary patterns instead of individual nutrients and foods. And so this holistic approach is becoming more and more popular. Another aspect of nutritional epidemiological research, which I don't want to talk too much about and just really want to mention it very briefly, is how to measure the diet. And I think the one thing that I would like everyone to remember is that it is very, very difficult to measure diet. There are different methods and tools that we have that can help in this endeavor to measure precisely what a certain individual eats. But all of these methods have their advantages and disadvantages, and neither of them are perfect. So whenever you read a paper or planning to carry out research in this field, it's good to remember that measuring the dietary intakes is a really very challenging task, and often one of the biggest limitation of any nutritional epidemiological analysis. Another possibly even more interesting question that we want to ask and answer at the beginning of this talk is, why is diet important for our health? Why are we talking about it? So here I would like to refer to the Global Burden of Disease project. I think hopefully many of you have heard of it. If you haven't, I really recommend to take a look at it, because it's a very interesting international collaboration between various research groups and institutions, and they do global level analysis. And one of their work, or one of their analysis, is when they try to examine the extent certain risk factors or causes of disease, you can call them, contribute to the overall death and disease worldwide that occurs. So here, for example, in this graph, you see the most important causes of chronic diseases that contribute the most death and disease worldwide. And you can see that on the top, it's high blood pressure, which is responsible about 6, 7, 8% of disability adjusted life years, which is like an indicator of disease and death worldwide. However, if you look at the list, you can see that so many of these biggest killers or those risk factors that most responsible for our ill health are connected to nutrition. For example, diet low in fruits, diet high in sodium, diet low in nuts and seeds. These are all important contributors of death and disease worldwide. And there are many other risk factors here, for example, high blood pressure, which is on the top, that not directly connected to, not a dietary risk factor, but very strongly related to nutrition. So, for example, many of you probably know that high blood pressure often is a result of high salt intake. So indirectly, even these non-nutritional risk factors contribute to our ill health. So I think overall, it's not exaggeration to say that unhealthy diet is one, if not the most important cause of death and disease worldwide. In fact, WHO estimated that about 50% of all cardiovascular disease death is to some extent due to unhealthy diet, and about 20% of all death worldwide to some extent related to unhealthy diet. Here in this graph, it's also from the same project, once a bit later publication, and unfortunately the letters are very small, so I'm not sure too many of you are able to read what is on this list. But what I just wanted to highlight, that it's another way how the risk factors, these global risk factors, are combined. And when we don't look at them individually, like fruit intake or nut intake or sodium consumption, but taking them together as dietary risk factors, they are on the top of the list for both men and both women. So I think this is important to remember, that just a very good illustration how diet is important to our health. Two small details I also wanted to mention here is the issue of quantity versus quality. Because when I talk to people, often people, even researchers, think that, or say that nutrition is all about the quantity and the amount we eat and the energy consumption, and whether no question that energy intake is very important and has a huge impact on obesity rates worldwide, and obesity is another pandemic that is going on, maybe not just this year, but over the last few decades. So that's quantity is a very important aspect of diet, but it's not the only aspect of diet. Quality, but what kind of foods we eat, in addition to the overall energy that we consume, is also another important factor. So you can very easily imagine individuals whose overall energy intake is absolutely within the recommended range, but the quality of their diet is terrible, and their eating habits are very unhealthy, despite consuming the amount that is recommended. So I think it's good to make this distinction between diet quality and quantity, and how they individually can affect disease occurrence and our health. Another important aspect of diet, an unhealthy diet, is the fact that it is modifiable. And this makes it very, very relevant for public health interventions, because if we know what is healthy and what is unhealthy, we have the opportunity to change it and make people eat healthily, and that in that way improve the health of the population. So as opposed to, for example, genetic risk factors, which you can't really modify, uh, diet is modifiable and very much target of public health interventions. So what is healthy diet? I think many of you probably have ideas of what are the foods nutrients that we should eat, and what are the foods and nutrients we should avoid. And here in this table, I collected information from the latest advice from the US US Department of Agriculture, from the US Dietary Guidelines, where they list a number of food items or food groups which can be suggested to be part of diet if you want to create a healthy dietary pattern. And there are a number of food groups which should be avoided if you want to eat healthily. And I think what I want to illustrate here is that every week there are hundreds of nutritional epidemiological studies published in the scientific literature, all looking at the relationship between various nutrients and foods in relation to chronic diseases. So there is a huge amount of evidence published on a weekly basis, and these studies often summarized in systematic reviews, meta-analysis, to put together the available evidence for a certain nutrient in terms of a certain disease. And these dietary guidelines, like this one from the US, they all bring together that awful large number of evidence that is available out there, and provided for the not just for scientific readers, but for everyone who is interested. So I just want you to appreciate the huge amount of work which underpins this fairly simple table here. These evidence obviously changes, and so these guidelines need to be revised every couple of years. So in the US, they do it every 5 years. But I would say at the moment, these are the most recent guidelines that is published just a few months ago, in fact. So these guidelines are related to specific nutrients and foods, and there is also evidence regarding overall dietary patterns, the third component of our diet, as I mentioned in the first slide. And one dietary pattern regarding which the evidence is really, really strong is the Mediterranean diet. I'm sure I'm not telling anything new here, and most of you are very well aware that Mediterranean diet is a dietary pattern which should be followed. And I am also a big advocate of Mediterranean diet, and the reason why the evidence is so strong is because both observational and interventional studies proved the the healthfulness of this dietary pattern, and that's the evidence that underpins the usefulness of Mediterranean diet is also very strong. Okay, so we know what healthy diet is, but what can we do with it? What can we do to improve the diet of any population? So this is another aspect. This is where I start to talk about public health nutrition. So not everyone makes this strict distinction, but some authors do, saying that epidemiology is is the science that provides the evidence, and then the public health is the one that uses this evidence to help prevent the occurrence of diseases. So so far I've talked mainly about nutritional epidemiology, and now a bit about public health nutrition. And the main question, as I said, is what can we do to improve the health, improve the diet of the population, and through the diet improve the health of any population. So generally, there are two main things that we can do. One is to target the individual and try to educate the individuals about the principles of healthy nutrition and improve the knowledge on healthy nutrition, because people can eat healthily only mainly if they know what is healthy. And that's definitely a very important aspect of public health nutritional interventions, of teaching people what healthy nutrition is. But there is another approach, and some authors say it's probably even more effective, is not just to target the individual, but target the environment that we live in. In other words, try to make it easier for the individuals to make the healthy choices, sometimes even without them knowing it. So try to change the environment that we live in a way that it will be very easy for us to shift towards a healthier diet. I will just give a few examples for this. So regarding targeting the individual and educating uh, people about healthy nutrition, there are plenty of examples about nutritional educational campaigns. You know, the 5-a-day campaign, the Change for Life campaign, the Eat Well Plate. These are and I hope many of you have met these graphics and they, you know what they entail. There are obviously very important educational opportunities in schools, and teaching healthy diet in children is a very important aspect. But as I said, the other aspect is, or their approach is to change the environment and make it easier for the individuals to make the healthy choices. So here there are policies that can be applied and can target availability and accessibility of certain food items. So there are a few examples where we don't focus on the individual but focus on the environment and trying to make the environment healthier. For example, applying taxes and subsidies. So taxing unhealthy foods, provide subsidies for healthy foods. Some of the countries have tried it. In fact, the UK has introduced sugar tax on certain items. I will give you an example from another country how this can be done, and sometimes it is actually very effective. Labeling can be important, where you provide on the package of foods the content in terms of key nutrients, and that meal will make it easier for people to see what is inside that food, and they are able to make the choice between healthy and unhealthy ones if they are at the same time. Advertisements is another way. It's just very similar to tobacco or alcohol ads, uh, and there are policies, regulations on this sometimes, and mainly targeting children. There are very strict regulations. Workplaces and schools are very important opportunities where we can change the food environment where we live in, because I mean, not anymore. We don't spend too much time in workplaces anymore. at least not last year, but previously we did. And the food that are available there can make a difference to our diet, and the same applies for schools. So I mentioned that I will give you an example about the sugar tax, how this can be effective. This example comes from Mexico, where in 2014 they introduced tax on sugary drinks, and here in this graph you can see the consumption of sugary drinks before the tax was introduced. That's the blue line, and how the consumption changed after the sugar tax introduced. It's represented by the green line, and the red line shows, it's kind of modeling how the consumption would have happened if there had been no tax introduced. And you can see that there are really nice gaps indicating that the consumption of these sugar drinks reduced considerably compared to what it would have been as a result of taxing. And another important aspect of this, that there are three graphs here because of the three different socioeconomic categories, and you can see that the gap between the actual consumption and the consumption which would have been without tax is the biggest for the lowest socioeconomic class. So this is a promising result, which suggests that with introducing tax on sugary drinks or unhealthy foods may not just improve the diet and health of the population, but maybe also help to reduce social inequalities in the population. I wish all the examples from the past would be this effective. I can't say this, unfortunately. Some countries have less good experience with sugar drinks taxing, and some countries still collecting data on the evidence, but this is just promising data that suggests that this might be an effective way forward. Just a few more examples. One is Jamie Oliver intervention. I don't know how many, I'm sure everyone knows Jamie Oliver as a celebrity chef, but I'm not sure how many of you know his contribution to school meals and how much work he did to improve the quality of the food that children can get in schools. So I don't want to go into details because of the lack of time, but it's an interesting story how the impact he had on school meals, mainly in the mid 2000s here in the UK, and how partly thanks to him, the children who are in school today eat much more healthily than for example their parents. And this isn't just an example for food labeling, where you can see it's a kind of traffic light system where you can see what is inside the food like in a pizza or in a cereal. I don't, if you haven't checked these traffic lights on the packaging when you go shopping, maybe you can do it now, and based on the colors, people can make their choices. Okay, so this was mainly the first part of the talk. In fact, there is one more slide which is about this first introductory part of my talk about nutritional epidemiology and public health nutrition. So here in this slide, I just want to mention very briefly the concept of the social determinants of health, mainly because this is relevant from the public health nutritional point of view in terms of interventions, and it is also relevant for the study that I will introduce in the next part of my talk regarding traditional Eastern European diet. So very briefly, the social determinants of health concept, the idea is that our health depends not just on our immediate lifestyle factors, on whether we smoke or not, whether we do physical exercise or not, or what we eat, but it also largely determined by our wider socioeconomic characteristics and environmental and the environment that we live in. So, for example, it also depends on our education, on our work environment, on our housing, and also the physical and cultural environment that we live in. These social economical factors can affect our health through directly, but also through by influencing our lifestyle. So in the next part of my talk, I will illustrate how our culture, our cultural identity, can have a huge impact on what we eat, and through what we eat, it has a huge impact on our health. So that's where I'm going now. Going to the next slide. So here I really finished the first part. I hope it was useful, and it was really very general, and maybe even for those of you who are familiar with this concepts still heard something useful. But now I will move on, and I will start explaining or describing a very specific study that I was involved in, and which study focusing on traditional Eastern European dietary habits and the mortality within the HAPIEE study. So, as Yolanda mentioned at the beginning, I'm at UCL. I'm part of the Eastern European Health Research Group, and much of our work is focused on Eastern European populations and trying to find ways or understand the health or the risk factors for various diseases in this part of the world, and also how to improve the health in this country, in these regions. So, but this particular analysis was part of a larger project, which was interdisciplinary project within UCL. And in this project, the title of the project was Cuisine, Culture and Consequences, Food and Diet in Eastern Europe from Cultural and Public Health Perspective. So within this project, very strong emphasis was put on interdisciplinarity. And so the participants of the project were coming from the public health and epidemiology side, like myself. We were from the public health department, but we worked together with historians, sociologists, anthropologists, economists from another department in UCL called the School of Slavonic and Eastern European Studies. So they were more social scientists, and we brought in the epidemiology public health side. And we also had colleagues from outside UCL and from Poland, Bulgaria, Hungary coming and bringing together their knowledge. So it was a true interdisciplinary research, which is still rare today, despite a lot of calls for engaging more in this kind of interdisciplinary research, not just in Eastern Europe, but in any field of research. So this, I think it was a really good example for a proper interdisciplinary work. And basically what we did, we tried to look at the relationship between culture, diet, and health in the Eastern European context. Why it is important to look at diet in Eastern Europe? I'd like to give some background to justify our work. So I think, don't know how much you know about, I think many of you probably know a lot about the history of Europe in the 20th century. And I think most of you know that in the second part of the 20th century, the European continent was divided in the middle. And there was Western Europe, which had a capitalist system. And it was on the other side, there was the Eastern Europe with a more communist and socialist political system. The terminology is not entirely clear, but sometimes the countries that were part of the Soviet Union up to 1990, they are called today the countries of the former Soviet Union, and countries which were not part of the Soviet Union but were part of the Eastern Bloc, east from the Iron Curtain, like Poland, Czech Republic, Hungary. These countries are sometimes called the Central Eastern European countries. So the Iron Curtain that divided these two regions fell almost exactly 30 years ago. But I would say that the impact of this political division between East and West can be still felt today, and it still has an impact on people's life and health. So, for example, if we look at life expectancy in these three regions, you can see that in the 1970s, the life expectancy in Western Europe, Central Eastern Europe, and former Soviet Union was very similar. However, since then, there is a steady increase in life expectancy, both males and females in Western Europe, while in Central Eastern Europe and former Soviet Union, there was a stagnation and even decline in life expectancy. And today, there is about almost 10-year difference in life expectancy at birth on average, between Western Europe and the former Soviet Union. So that's a very big gap. And this gap can be also seen if we look at specific diseases, particularly when we look at cardiovascular disease. So we see a very similar pattern, obviously opposite way, that we see that the cardiovascular disease death rates were very similar in Eastern Europe, in the various regions of Europe in the 70s, but clear divergence can be seen over the 80s and the 90s, where improvement were seen in Western Europe, but steady and increasing rates in the Eastern Bloc countries. In terms of cancer, there is no clear picture, no such clear picture between East and West, but there are some specific Eastern European countries such as Hungary or Czech Republic, where the cancer rates are world leading, not just highest, not just in Europe, but in the world as well. So, for example, lung cancer, colorectal cancer, cancer of the oral cavity are higher in Hungary than anywhere else in the world. And the big question is why? Why is this gap there between East and Western European countries? Why are cardiovascular disease rates so much higher in Eastern Europe compared to the West? Why there are so much higher rates of cancer in certain Eastern European countries? So over the last few decades, there have been several studies looking at this question and trying to answer this question, and several distal and proximal risk factors have been identified, which play a role in the poor health of Eastern Europeans. Particularly, if you look at the lifestyle factors, there is quite strong evidence showing that alcohol consumption and smoking plays a big role, and the prevalence of heavy drinking and smoking is still very high in Eastern European countries, and these lifestyle factors definitely play a role in the poor health of Eastern Europeans. The question is also there that whether diet also plays a role. Is it possible that dietary habits in Eastern Europe may contribute to this gap that we observe in terms of health? But the thing is that diet is a much more complex lifestyle habit compared to smoking and alcohol, and its measurement is much more tricky, and consequently the evidence regarding the contribution of certain dietary factors in the poor health of Eastern Europeans is much more limited. So there are a few studies which looked at it, and then there is some evidence which suggests that the Eastern European countries, the consumption of fruit intake is low and animal fat consumption is high, and these may contribute to the poor health. But the overall dietary pattern, which is typical or traditional to this region, has not really been explored. And this is what we set out to do. We set out to try to identify the traditional Eastern European diet and to explore whether it may contribute to the high cardiovascular disease and cancer rates in this region. At this point, I think I want to just make a little detour and ask a question, or try to answer the question: what is traditional diet? Which is a very difficult question to answer, to be honest, and mainly because the word traditional has a very complex and loaded meaning from the historical and sociological point of view, which is a bit more, what is a bit more easier if we want to get closer to our topic, if we want to define what traditional food is. Because for traditional food products, there are some fairly consistent and compact definitions in the literature, coming mainly from two studies, True Food and the Eurofear studies, published in the 2000s, and then funded by the EU. And in fact, the European Commission has a fairly good definition for traditional diets. And in fact, this big interest in traditional diet came in the 2000s, came from the commercial side, because maybe you can guess that foods which have the label traditional on it, they often sell better, and the shops can sell traditional foods higher price because they are popular. So the EU commissioned these studies to make the definition a bit more straightforward, more clear, and more harmonized across countries and across the various shops which sell these products. Anyway, for research point of view, these definitions, to be honest, not terribly useful, mainly because they have never been used in a specific context, and they have never been used in research before. Another approach, and in fact what we followed in our project, is to see whether any other areas have a defined traditional diet and published in the international literature. And in fact, when you look at the literature, you find a very good example for traditional diet, which is the Mediterranean diet, and I mentioned before, because Mediterranean diet is defined as the traditional eating habits of communities around the Mediterranean Sea. So in our project, we decided to look into how this Mediterranean diet was defined and maybe apply that approach to the Eastern European region. And the way Mediterranean diet, the definition for Mediterranean diet came from, it's from the 7 country study that was one of the first nutritional epidemiological study ever conducted, and done in the 1950s and 60s, when led by an American epidemiologist called Ansel Keys, who collected data in 7 different countries around the world, including Italy, Greece, and former Yugoslavia. And what he noticed that life expectancy in some of these Mediterranean countries were better than in the other observed countries, and his theory was that the diet in these regions play a role. And what he did, basically, he used the rural, and yes, so the data collection was taking place in the 50s and 60s in rural communities in Italy, Greece, and the former Yugoslavia, and he used this the dietary habits of rural communities in this region to define Mediterranean diet. And this is what we set out to do. Eventually, we decided to try to explore the dietary habits of rural communities in Eastern European countries in the 1950s and early 60s, and and try to use this diet, what they followed in those years, in those areas, to define traditional Eastern European diet. In addition to the similarity with the Mediterranean diet, there were a few other reasons why we thought that focusing on the 1950s and early 60s era, and particularly in rural communities, would be a good idea. The reasons were that at this time, in these areas, most food items were still produced locally with ingredients grown or bred in the local household. So these villages or village communities were still mainly self-sufficient in this time. Also, food preparation and preservation methods did not, or very rarely, include modern cooking techniques or household items such as electric cookers or gas cookers or fridges, freezers. So putting this all together, it's not impossible to assume that rural populations at this time still followed the lifestyle and eating habits which had been dominant in the previous decades, potentially previous centuries. In the mid-60s, life changed in these rural communities because modern household devices appeared and village shops grew in number and size, and people started to buy the ingredients for their cooking instead of producing it themselves. So that's why we had this cut of mid-60s, when we thought that we should focus the times before this era. So using data from historical dietary surveys, from ethnographic studies, from secondary literature sources, and also by talking to local experts, we identified 9 food groups which were regularly consumed by individuals in these rural communities in the 50s, early 60s across the Eastern European region. So these 9 food groups, food groups, could be potentially considered traditional if we follow this way of defining traditional diet as we did. So this is where the first part of this project ended, and this was mainly done by historians and sociologists, and they came up with this list, as I said, using this definition and using data from historical records. And in the next part of this project, we use this information to see whether the dietary habit that is characterized by these 9 food items is healthy or not healthy, or whether this dietary pattern can contribute to the development of cardiovascular disease, cancer, or other chronic diseases. And to do this second part of this analysis, it was a pure epidemiological analysis, as much as the previous part was mainly sociology and history. And to test this theory, or to analyze this food pattern and the relationship with health outcome, we use data from the HAPIEE study. So just a few words about the HAPIEE study. The HAPIEE study is the abbreviation for the Health, Alcohol, and Psychosocial Factors in Eastern Europe study, which is one of the largest and the most recent prospective cohort study with available dietary data. The baseline data collection took place in 3 countries, Czech Republic, Poland, and Russia, in the early 2000s. In each of these countries, about 10,000, slightly less than 10,000 people were recruited to participate in the study. And since then, they have been followed up. So we know whether they develop cardiovascular disease, whether they develop cancer, whether they die. And we can analyze not diet and other characteristics in relation to health outcomes. Dietary habits were measured with food frequency questionnaire at baseline. In this current analysis, what we did, only about 18,000 of these 28,000 participants were included. And from this number of participants, 2,200 234 died during the follow-up that was included in the analysis. Then, in the first part of the statistical analysis, we wanted to see how closely the individual participants of this study follow the traditional dietary pattern that is characterized by those 9 food groups which we identified earlier. And to do this, we developed a diet score, which we named Eastern European Diet Score. And the way how we calculated this Eastern European Diet Score is very similar how the Mediterranean Diet Score is calculated and published in many previous studies. So basically, we categorized the sample into 3 groups in terms of all 9 components, and people, or all individuals, or all participants who consumed relatively small amount from a specific component, they were given 0 point for that particular component, and those who consumed high amounts from the component, they received 2 points. And these component scores were added up for every single individual, and so there we got the overall Eastern European Diet Score for every participant of the study, ranging from 0 to 18. And this score means, or the score that was given to every individual means that, so if any participant of the study received high score, or their Eastern European Diet Score was close to 18, then we can say that that person eats quite a lot from all of these traditional food groups, and their overall pattern is also probably very close to the traditional pattern. On the other hand, people or participants who do not consume large amounts for many of these components, they receive 0 points, and their overall score will be close to 0 or will be low, and they do not follow the traditional dietary pattern. So here you can see the proportion of participants with high Eastern European Diet Score in certain subgroups of the sample. So for example, we found that 20% of the sample scored 11 points or higher in this scoring system. Participants from Poland were more likely to score high compared to Russia and Czech Republic. And as we expected, people in older age groups were more likely to score higher, more likely to follow the traditional pattern compared to younger individuals. Oh, and here, I'm afraid it's not really, the slide doesn't show very well in this version. Anyway, this is supposed to be the main findings of our study, where we show the multivariable adjusted hazard ratios of all-cause mortality, cardiovascular disease mortality, cancer mortality, and other non-CVD, non-cancer mortality across 3 categories of the Eastern European diet score. And what you don't see here, unfortunately, because of the format, but I can tell you, what we found is that in terms of all-cause mortality, we found that people who scored high for the Eastern European Diet Score, meaning that their consumption, their dietary pattern was close to the traditional pattern, they had significantly higher risk of death compared to those who scored low. We also found significant association in terms of CVD. So people who scored high and followed closely the traditional dietary pattern, they had about 30% higher risk of dying from CVD compared to those with low score. For cancer, we also found a positive trend, but there was no statistically significant association. And we found no clear trend or clear pattern in terms of the other non-CVD, non-cancer causes. Here, once again, it's not great, but I can explain what you should be seeing in this graph. So here we looked at not the overall dietary pattern in relation to the same disease, the mortality outcomes, but we looked at the main components of this pattern, the 9 components in relation to the outcomes, and we found consistent patterns for 2 of the components. One is the preserved fruits and vegetables, and the other is for lard. And what we found that individuals who consume relatively large amount of preserved fruits and vegetables, including sauerkraut, pickled gherkin, or even jam, they had significantly lower risk of overall death and CVD and cancer death compared to those who consumed lower amounts of this food group. On the other hand, lard also showed very consistently that, but in the other way, that people who consumed large amounts of lard or said that they regularly cook with lard, they had significantly higher risk of all-cause CVD and cancer mortality rates compared to those who do not cook with lard or eat lower amounts of it. So, as a summary for this second part of my talk regarding the analysis, I would say that defining traditional dietary habits in Eastern Europe is a very challenging task. Probably that was the most challenging part of this analysis or this project what we carried out. Nonetheless, the Eastern European diet score, which is based on food groups regularly consumed by rural individuals in the 1950s and 60s, is one possible indicator of the traditional eating habits in this region. And we also found that these traditional eating habits may contribute to the poor health status, particularly the high cardiovascular disease mortality rates in Eastern European populations. And finally, I can say that the role of specific food groups such as lard may need further attention and analysis, and they potentially can be good targets for public health nutritional interventions. So that's it, what I wanted to talk about. I think just on the dot of 1 hour. Yeah, so I finished. Basically, just to recap, I talked a bit at the beginning from the general overview about nutritional epidemiology, public health, and in the second part, a bit of specific analysis on traditional Eastern European diet. I hope you found this hour useful and you enjoyed the talk. Thank you for your attention.
Thank you, Dan. Thank you very much. I'm sure there will be lots of questions from the floor, from the audience. So I'll start checking if you would like to raise your hand and use your mic, or otherwise you can type your question in the chat box. See some people reconnecting. Isabel?
Hiya. I love that talk. Thank you for that. I was just going to ask, it's moving that whole, which is persistence.
Ooh, Isabel, I'm really sorry. I can't really hear. I think your connection is not great.
Like
Maybe
large.
will you try to type it in the chat?
Type in.
Yeah, I think it would be just help because I can't really hear.
So will we wait to Isabel? Probably she's typing. I can see many students, I assume, and colleagues from public health nutrition, the MA, some colleagues from human sciences as well. So I have a question in between while we wait for Isabel or others to pose their questions. I was just interested in what you talk about, this interdisciplinary work, and it was very interesting to see how the concept of what was one important, well, the core of your project, I will say, how to define this traditional dietary pattern in Eastern Europe, was coming from a historical and sociological perspective. How can just more on the ground? I mean, how would you say how difficult was? Two questions. How difficult was for you guys coming from epidemiology in completely different context to engage in that interdisciplinary discussion? And the second question is how easy has been for you to publish together, or what actually whether you managed to publish together in journals, because sometimes it's quite challenging.
Yeah. So first of all, regarding how easy or difficult it was for us or for anyone, to be honest, it was challenging, but the feedback I received from colleagues and what I felt, it was very almost refreshing, because we tend to work in silos and we tend to talk to the same people all the time about the same concept. And when you go out of it with an open mind, you can hear approaches that you would never think about on your own, or just if you talk with your colleagues. So I think sometimes it was really difficult in terms of terminology, and then to whether sometimes we use the same different terms for the same things, and by the time we realized that we are talking about the same things, it took some time. But if overall, so for example, we had a few days when everyone was in the same room and we spent the whole day just brainstorming and discussing these issues from the two angles. And everyone, or most of my colleagues and who were there, said that they very rarely have this kind of conversations, but these conversations spark ideas that don't come up on a day-to-day basis when you just with your own discipline. So yes, it was definitely challenging. And to find, for example, how to complement each other and not just to work independently, but how we can merge the two sides together. And by finding that traditional pattern, which will be eventually used in an epidemiology context, that's how we found the kind of connection points. So it was challenging, but it was very enjoyable, and a lot of fun, and gave opportunities and thoughts that we never had come up otherwise. In terms of publication, well, I was the lead author, and I was the PI of the project, so I know it firsthand. And I mean, it is like the drafting and the writing is very similar, like with everywhere else. You write a draft, you send out, and you get lots of comments, and people comment on their part what they are more familiar with. So in that way, it wasn't too difficult, and it wasn't more difficult than a general project with lots of participants. And the publication was also. I mean, we published it eventually in the European Journal of Nutrition, so it's an epidemiological paper journal. So we stayed in the epidemiology side and didn't publish it in the history or sociological side. But based on the reviewers' comments, I thought this kind of interdisciplinary approach was appreciated. And of course, we had lots of comments, but it wasn't more difficult than any other nutritional epidemiological paper that we published before. And yeah, I don't know if I can put, maybe I can put in the chat. It's already published and anyone can read it. It's open access.
Okay,
So,
that's very
so
helpful, Dennis.
maybe,
Yes,
let me
that's
just
great.
try, because it's yeah.
I think also Eileen O'Keefe, who is emeritus professor in public health, but also Eileen, you're still in UCL as well.
Well, I'm really emeritus at your place, research person there. But what I wanted to ask Dennis is, am I there?
Yes,
Am I
yes,
there?
yes, I can hear you. Yeah.
What I wanted to ask you was whether you've worked with specifically with anthropologists, because at SOAS, the food studies group, one of the people who, you know, they are having people getting PhDs in anthropology. And there have been some very interesting studies that have been done for PhDs by, I'm thinking, for instance, about Anna Colquhoun, who did her PhD on food in Croatia, and who then made links between the food. She worked directly with people in Croatia itself, then became very interested in food cultures right here in London, involved with Eastern European populations. And I must say, whenever I go into any of the, whenever I go into any of the shops where I am looking for what I call East European ingredients, it seems to me those locations right here in London are a wonderland for being able to do that kind of anthropological research, which would enable us to really look at changing patterns in dietary behavior amongst people in these complicated cities such as London. I mean, that's why I ask whether you actually involve anthropologists in the study that you do.
Yeah, so in this particular project, I had colleagues from the Central Eastern, from the School of Slavonic and Eastern European Studies. They were mainly historians,
yes.
sociologists. For example, Diane Kunker, who is the head of the whole school, was part of it. And I don't know if you saw the names, Elodie Douarine, who she's actually an economist. Then Boyan Alexov, he's an historian, and Daniel Brett, he's a historian. So mainly historians, sociologists, but those who work in the food area.
Yes, yes.
So and also from Eastern Europe, we from Bulgaria, Poland, and Hungary. We from Bulgaria and Poland we got sociologists and historians, and Hungary we got public health person. So I think you are right. We had input through them from anthropologists, I think, when they were doing the work, but within the close the project members, and they are all in the paper. So for example, you see who were named, they were not an anthropologist. But it's a very good point. Yes.
Yeah, it's a lovely paper. Thank you very much.
Can you just say the name of that person who you mentioned? Can I just?
Anna Colquhoun. I'll tell you. I'll see if I can find out, because she was amazing, because her name is Anna Colquhoun, and you spell it Colquhoun. And what she's ended up doing, what she was very interested in as well is food cultures as engaging food cultures as a way of exploring transformations in Central and Eastern Europe. So, for instance, one of the things she looked at was the way in which food was being used in the tourist industry in Istria, and the way in which there was a whole move to emphasize the sophisticated nature of Croatian food for people who had fallen in love with Italian food.
Yeah.
And you know, so and you can see the connection if you wander down to Borough Market, because there is that Croatian, there is, you know, there is a Croatian food stall there.
Yeah.
And the emphasis is on, you know, this might remind you of Mediterranean food.
Yeah. Yeah.
And she's now involved in Croatia itself in carrying on further on the ground participant observation in the transformation of tourism by highlighting sophisticated food, which is Croatian food.
Yeah. Yeah, that's very interesting. Thank you. Thank you very much. I will look into it. Might get in touch with her.
Lovely.
Thank you.
Bye-bye now.
Thank you.
Thank you,
Lovely
Eileen.
talk.
Thank you.
Bye.
Thanks, Eileen. Dennis, this Isabel, she has
Yeah.
typed. I don't know if you can check on the chat, or
Yeah,
you want
yeah,
me to read?
yeah.
Yeah, you can.
No, I can. So you mentioned looking at the whole diet approach is becoming more common, but issues around lard was a specific notable outcome from the study. Do you think the whole diet holistic approach is still the best method of research going forward, and that other diet types could we look into in the future? It's a very good question. Excellent. Both, you know, they call it the reductionist approach when you look at specific nutrients, foods, and the holistic approach of the dietary pattern. They all have their advantages, disadvantages. So, for example, the big advantage of the holistic approach when you look at dietary pattern is that, for example, the issue of compounding is less prominent. So I don't know if how much familiar. This is a big problem in any epidemiological study, that you may, you know, for example, if you look at meat, the reason why you find meat is bad for you because you also eat less fruit. You know, there is such an interconnection between different foods and nutrients. And when you look at overall dietary pattern, this kind of confounding with each other is less prominent. So that's an advantage. On the other hand, it is the disadvantage, and exactly that you pointed out, that it's very difficult to apply total pattern in a public health intervention. I mean, maybe as a Mediterranean diet recommended, and if it is emphasized every component, then it's possible. But the reductionist approach, or when focusing on specific foods, is much easier to include in an intervention. And for example, that's why we did this way, that first we looked at the overall pattern, but we looked at the individual components of it, because the individual components are better to grasp or hang on or promote. It's just an easier concept for the public to understand rather than the overall pattern. But the overall pattern is very important, for example, to show that diet is so important in this area. And as I said, methodologically, it has its important advantages. So I hope I managed to answer your question.
Yes, thank you so much. Yeah, I was just thinking, because obviously as a whole diet approach, certain things might have like a synergistic effect, which you wouldn't see with just seeing one nutrient at a time. So that could be another advantage of it, I guess.
Yeah, absolutely. Thank you.
So I'd pitch in with another question while we wait on the people, if they will, of course, they would like to ask question, or raise your hand or type on the chat. You mentioned at the end, because of lard being so somehow isolated as being something prominent in the rates of cardiovascular disease and cancer, and all-cause mortality, I guess, as well. What sort of intervention do you think I don't know if this is something that you're working alongside public health, more specialist in terms of messaging. I mean, what sort of intervention do you think could be effective, or probably if you have designed anything, any type of intervention to tackle that?
Yeah, I mean, so I work mainly in epidemiology, so I don't.
Yeah.
At the moment, I'm not really in designing interventions, but what I would say could be useful, and it has worked, is replacement. So first of all, finding those communities, because those communities where lard is still very popular, so like in many Eastern European countries, and proposing replacement oils for cooking. Like it's clear evidence that replacing animal fat with vegetable oils or olive oil is good. It will improve health outcomes. So we can't just say not to use lard, because some people need some grease to cook, obviously, but there are much healthier options, such as sunflower oil, olive oil. And then if this message can break into those communities, it makes a big difference. I'm from Hungary, so I know the cultural sides, and even in my family it's hard to replace because the cultural element is so strong. But that's the work for public health nutritionists.
Okay, thank you. I'm not sure if there are any other comments or questions. Otherwise, okay, maybe there are not some. I'm checking on the chat. Okay, so then it has put this in PubMed. Sorry, the link for
Yeah,
the
the link.
HAPIEE study.
This is the study I described. This is the analysis. So the relationship between
Okay.
traditional diet and mortality. So all the methodological details are in this paper. So if you're interested, you can read.
Thank you so much. That will be, yes, very useful to after listening to your talk. I mean, to look at those graphics again, and to see a bit more on the contributions of this is the interdisciplinary paper. I suppose, yes, the one that
Yes,
you explained.
that's right. Yeah.
That's very interesting. Okay, then it's I don't see for the moment any other question. Lots of people logging in and logging out, but having difficulties, I shall say, with connection by the look of things. Thank you so much, Dennis. It was really, really interesting to hear about this, interdisciplinary work, and very unusual for an epidemiologist working in this way. And I hope the audience will have gained quite a lot of insight into pros and cons and the type of work that can be done. Thank you so much.